So chronic inflammatory condition of lung airways with episodic reversible airflow obstruction, airway hyperresponsiveness. So what is our main goal? So less inflammation will lead to better asthma control. So main reason for delivering this lecture is to emphasize on this. So better asthma control we need to achieve. And exacerbations, please be liberal about intervening early with systemic corticosteroids in cases of exacerbations. So etiopathogenesis in short, in a susceptible host, environmental exposures and inherent susceptibility will lead to abnormal immune response to common exposures, which leads to prolonged pathogenic inflammation and aberrant repair of injured airways. So ultimately leading to lung dysfunction and airway remodeling. That leads to altered airway at mature ages. What this does is ongoing inflammatory exposures will lead to persistence of the condition and increased risk for severe exacerbations. So this is a normal airway, and this we can see how significantly the lumen has decreased in the diameter. So this is in short pathogenesis. The allergen incites immune response by stimulation of mast cells and release of chemokines and pro-inflammatory mediators, which lead to subepithelial fibrosis, bronchoconstriction, hypertrophy, hyperplasia, mucus hypersecretion leading to excess mucus production, and leading to airway obstruction in turn. So pathogenesis again depicting the same things. So what we need to remember is biological and genetic risk factors will lead to inherent susceptibility to the environmental allergens, leading to lower airway injury first and aberrant repair, and leading ultimately to asthma. So this is in short the summary. In this slide, I would just like to emphasize early phase reaction, mast cells are responsible, and late phase eosinophils. So here is the more irreversible phenomenon that takes place. Genetics, more than 100 genetic loci have been documented. Asthma triggers, we all know, viral infections, pollutants, strong odors, cold dry air, exercise, crying, laughter, hyperventilation, even pets and comorbid conditions will predispose to the asthmatic tendency. What are the early childhood risk factors for persistent asthma? This is something to be emphasized because parental asthma, you should be alert if parental asthma history is there. Allergy, in infancy if child is having tendency of eczema or allergic rhinitis, then and severe LRTI in early infancy, low birth weight, male sex, male gender, reduced lung function at birth, and most important, if they don't stick to exclusive breastfeeding. So what are the clinical features? We all know what are the clinical features of bronchial asthma. Recurrent cough, more at night, 90% of the times, more at night or early morning, induced by physical or emotional stress, crying, laughing, shouting, exercise, cold air. This is the way in children we need to pick this up. Recurrent wheeze and chest tightness and often other comorbid conditions. Asthma patterns are transient non-atopic wheezing, persistent atopy-associated asthma, asthma with declining lung function. Why I need to mention is transient non-atopic wheezing resolves with age. Persistent atopy-associated asthma in less than 3 years, usually there will be reduced, if child gets affected with persistent atopy-associated asthma and onset is before 3 years, the child will eventually face reduced airflow by school age. If later onset more than 3 years, no airflow limitation will be there. So highest risk for persistence is in this case, persistent atopy-associated asthma in case of kids, and asthma with declining lung function. Severity classification, even before taking medications, intrinsic disease severity will decide. So this is most important because we treat according to this. So intermittent, mild persistent, moderate persistent, and severe persistent. Control classification depends on the clinical assessment after starting medications. So well controlled, not well controlled, poorly controlled. Management patterns, easy to control, difficult to control, exacerbators, and refractory asthma. So how do we formally evaluate asthma exacerbation severity in emergency care setting? A very important thing for PGs, please do concentrate. So we evaluate based on symptoms, signs, and functional assessment. So symptoms are breathlessness, the speech, how much is the speech affected, and alertness of the child. Signs, you will have to examine respiratory rate, use of accessory muscles, wheeze, pulse per minute, and pulsus paradoxus. Functional assessment will involve assessment of the lung function, where peak expiratory flow, where we will pick up percent predicted or percent predicted personal best, because here this is applicable in cases of small kids more, PaO2, PCO2 and SA2. So what are the asthma mimics? So when I speak about asthma, or I want to diagnose and label the cases of asthma, so I need to be aware of these mimics. So other mimics which are there are laryngotracheobronchiomalacia, laryngotracheobronchitis, vocal cord dysfunction, viral bronchiolitis. But more importantly, we need not forget upper, middle, lower respiratory tract infections, allergic rhinitis, chronic rhinitis, sinusitis, and gastroesophageal reflux disease. So coming to diagnosis, how do we diagnose? So I need to now pick up what? Lung function abnormalities and airway inflammation. So lung functional abnormalities I can detect by spirometry. So there is airflow limitation in asthma, as we all know. So low FEV1 and FEV1 to FVC ratio of less than 0.8. Bronchodilator response we need to assess. To inhaled beta agonist, usually reversibility will be there. So increase in the FEV1 more than 12% or predicted FEV1 more than 10% after inhalation of short-acting beta agonist. Exercise challenge will cause worsening in FEV1 by more than 15%. Daily peak expiratory flow and FEV1 monitoring is very important. Day-to-day or AM to PM a variation of more than 20% helps to pick up. There's one more, axial nitric oxide is also used for diagnosis. Chest X-ray will show what? Majorly, who will answer? PGs? What is the chest X-ray finding in asthma? So, there is hyperinflation in the X-ray, okay? And in case of severe asthma, you will see scattered opacities or scattered collapses. Allergy testing to assess sensitization to inhalant allergens is also to be done in severe persistent asthma. Management, most important is again educating parents. In this case also, every visit is an opportunity. Please clear misconceptions of the parents about the disease. You have to discuss the pathogenesis to emphasize daily control of medication. Fear of inhalers has to be removed. Steroids should be told that they are not exactly bad always. The parents, along with grandparents, need to be counseled for use of medications by MDI and dry powder inhaler methods. Individual counseling if they are adolescents. So in asthma action plan, there are two plans, daily routine management and action. Daily routine will assess regular medication, and the action plan will cover exacerbations or emergency medical care when the child has to seek. Second is ensure adherence, most important. Chronic condition, this is a chronic condition we are dealing with. Daily control of medication is needed. Symptoms are going to wax and wane. So that doesn't mean, and severe exacerbations are infrequent. But that doesn't mean that they did not adhere to the treatment. The adherence is must. But it is found that it is frequently suboptimal. Inhaled corticosteroids are underused 60% of the times. So regular assessment and monitoring is very, very important. So what we assess here is asthma control test scores. So this is a questionnaire, especially for more than 12 years and adults, depending on which we classify as well controlled, not well controlled, and very poorly controlled asthma. And in children, we have children asthma control test scores. Please remember 2 to 4 checkups per year is recommended for assessing and maintaining good asthma control. Assessment of risk. Here I would like to just tell you severity and frequency of exacerbations do require systemic corticosteroids. So don't just refrain from giving corticosteroids in case of severe exacerbations. Tracking the lung growth is very important in older children. So there is top-light zone system where there is not availability of spirometry and all, we can use peak expiratory flow, and we can know whether the child on treatment is under good control, less than optimal, or poor control. Green zone is the child is, if the peak expiratory flow rates are 80 to 100% personal best. Yellow zone is 50 to 80% of the normal or personal best, and red zone is less than 50%. Third most important is environmental control. So we have to control the allergic tendencies. Ideal is allergy testing in at least those with persistent asthma. Please treat comorbid conditions. Just 2 minutes. I would like to emphasize students here, intermittent less than 2 days per week, and they need short-acting beta agonist less than 2 days per week. And mild, moderate, severe will require, mild is more than 2 days per week, more than, and of symptomatic symptoms, and short-acting beta agonist needed to more than 2 days per week. And moderate will be daily symptomatic, severe is throughout the day with more than 1 per week nighttime awakenings, and extremely limited normal activity. Please remember here, exacerbations of any severity may occur in patients of any severity category. What I mean by is, intermittent may also present in exacerbations. So coming to one more thing I would like to tell is step up and step down approach. Please, as soon as the child comes in exacerbations, we have to start at higher level controller therapy to establish prompt control, and then step down once good asthma control is achieved for 3 months. Stepping down and stepping up is very important. Quick relievers, we classify it as quick relievers are short-acting beta agonists, inhaled anticholinergics, short-course systemic corticosteroids. Long-term controllers are inhaled corticosteroids. Here I would just like to mention that long-acting beta agonists are not very safe. Always use in combination therapy. And once one controlled asthmatic attacks, please discontinue long-acting beta agonist. Continue only inhaled corticosteroids. Combined inhaled corticosteroid and long-acting beta agonist improve baseline function. So it's very superior to even add on with leukotriene receptor antagonist or theophylline, or even doubling the inhaled corticosteroid dose. That's it. Okay, so there are other therapies, just biological therapies, allergen immunotherapy, and there is the stepwise approach chart. Medications are, all of you know, delivery devices and inhalation techniques as meter dose inhaler, dry powder inhalers, and nebulizers. But only thing is, I would like to emphasize, please use spacers with, in cases of children who are 5 to 6 years of age. And just this is the technique how a mother should hold the child, and they had to be sealed around. So for better delivery of the drug to ensure. And dry powder inhalers, you have to rinse the mouth, otherwise local complications will be there. Thank you.
Thank you, Shilpa madam, for the lucid talk.